You guys are probably sick of hearing me all the time, so you're going to listen to Dr. Burgos talk about the progression of respiratory failure, tracheostomy, ventilator support, you name it. So take it away.
Hello, everybody. I'm just going to start as usual, okay? We've talked about this a lot, multiple times in the ICU. When we go to the vent, and I ask you to turn it to the lowest FiO2, which is atmospheric FiO2.
Yeah, so what is atmospheric
breathing?
air? How much FiO2 are we breathing? 21%. Nailed it. Okay, good.
So this is what we're breathing, okay? And then it can go all the way up to 100. It can't pass that, okay? So, for example, if someone's in humidified room air, it's humidified and the FiO2 is 21%, okay? And then let's say we put somebody on nasal cannula, which is the progression, right? And we describe it in liters, right? You go up there and you turn it to 1-2 liters.
How much FiO2 does 1 liter of nasal cannula increase? How many percentage points of FiO2 does 1 liter of nasal cannula increase your FiO2 by? I'm asking the students, the residents, and the people that are with us. 1%? 10%? Yeah, depends where you read. I don't know that this is super scientific, but I always think about 3% for each liter of running through a nasal cannula. I like to think it's like 3% of an increase.
It's an estimate. And
it's an
it
estimation.
Depends on the mode you're giving it. So nasal cannula, and even if you bump it to the 15-liter max in the rooms, the max you can get is 44%, 44 to 50%. Okay. So that's from you go to here to 50 to 40, if 44 to 50%. If you max it out in 15 liters, yes. So then let's say the maximum on the wall is 15.
Is it the maximum in general?
No. With the nasal cannula, basically, yes. It starts losing its efficiency, basically. So you need a new system, which then there you tell the nurse you put them, yes. What's next? Somebody said it, but. So there's a couple of flavors you can do. Venti mask, okay.
Venti mask.
Simple. That's another thing.
These are the flavors of high.
And then there's high flow.
Escalation beyond.
And then
High flow.
Oh, got it. Okay.
Is it venti and high flow or high flow venti?
okay, so now we're gonna go in this sequence. Okay, we're going across. Here you go. You really can't see it, but it's the simple or the venti mask, and then the non-rebreather mask, and then you go to high flow, and then you go to BiPAP, and then you intubate the person usually. Okay. So the non-rebreather, it's good for people who are mouth breathers. Okay, because if you put the cannula in their nose, those are the goods for, and then you have to make sure that the reservoir is inflated. Okay, have the bag, it has to be ballooned up. If it's not, then you're not delivering the right oxygen. Okay, this is a transition for you to if you're gonna get set up for intubation, that's okay. You can put them on rebreather for a little bit, but you should have a reason why you're putting them on a non-rebreather. Okay, it's usually to get your stuff ready to get to the patient. Then what is the difference between the high flow and the non-rebreather or a mask?
High flow gives you positive pressure.
PEEP, which is good. So with high flow, you can adjust for PEEP too.
High flow has theoretical PEEP, not actual PEEP. It's only in theory. The other difference between high flow and non-rebreather is you have 100% oxygen with non-rebreather. However, with high flow, even at 65%, they've proven with studies that can actually be as low as 35% getting into the patient's airway. So you actually get more oxygen with non-rebreather than with high flow. Because it doesn't create a sill like BiPAP with high flow, that's why it's theoretical that it's actually getting that pressure into the lungs. it's not necessarily fully proven because you don't have that seal of BiPAP.
Yeah, so if you want pressure, you can use BiPAP or high flow because it has some pressure, okay? If you want purely oxygenation, then you would do like a non-rebreather, basically, okay? What else? So then after that, BiPAP, you adjust a lot. People who have COPD or smokers, they need pressure, they have obstructive sleep apnea, they're obese. All these patients, sometimes we put them, and the settings are, the basic settings are I-10 and E5. So the inspiratory pressure and the expiratory pressure. And that's what the order you put. Then they're gonna ask
Dr.
you how
Burgos,
high.
the fans are going to hate you. Use this.
Sorry, yes, I know. My handwriting is so bad.
They're going to comment on that too. Don't misspell anything. Don't misspeak. And you must do everything perfect.
Rebreather. This I can see. I don't know.
This is getting worse.
All right. Anyways, any questions about that? So this is more for oxygenation.
Would a BB mask fall into BiPAP? It's a
Which one?
category of BB mask, like about mask that we're bagging a patient. That would kind of fit into the BiPAP.
You can, if you, I mean, not really.
No?
Because you're just putting, I don't think you have positive and expiratory pressure. You don't have an
If you're talking about ambu bags, they actually do have PEEP.
PEEP,
Like they do
Oh,
have that
the
positive pressure you
PEEP,
can push in.
but the inspiratory pressure, it would be you. I don't know if you could just measure it as accurately, you know?
Okay.
It wouldn't have the continuous expiratory pressure that the BiPAP does, but it does
Yeah.
have inspiratory when you push in.
Yeah.
But like one number.
Yeah, it's just
Yeah.
one number going in, but when you release it, all the pressure's lost.
Yeah. Okay, and then we're gonna tube somebody. What tube are you gonna get? They're gonna ask you. We can go over the rapid sequence real quick because this is the next step. So what are Ryan? Let's see. Yeah, sure. But which size?
8.
Sure. So 8 is on the higher side.
Okay.
7.5, 7. You can't go wrong.
Okay.
You have to have your like average numbers in your head in the emergency moments. So yeah, 7, 7.5 is good for the size of an ET tube. And then what meds are you gonna ask for?
Depends.
You need to
Need
a paralytic, yes. And then okay. What are you gonna get first?
You don't want to
Sedative.
paralyze someone that's aware. So you're going to start with induction.
Okay, and then how much?
Depends on which one you choose.
Good. What are the favors of these paralytics and induction?
Succinylcholine and
Right.
rocuronium are going to be your paralytics, and then you can use ketamine, etomidate, or propofol, or like a lot of verses.
Ketamine.
If you're doing like the late sequence.
When do you choose one or the other?
It depends on the status of the patient. You can't lay
Their
them
blood pressure, their hemodynamics, all these things. That's how you're gonna choose. Let's say they're a renal patient, and you're worried about them, their electrolytes being off, their potassium. Someone in rhabdo. Which one would you choose between these two paralytics?
You don't want to use subs.
Okay.
And my most recent question, if you give somebody a paralytic and you do a pupillary exam on them, what is their pupillary exam going to be like? It's normal. It's unaffected, okay? It's unaffected. It affects skeletal muscle. Specifically, which one of those is a depolarizing paralytic drug? Exactly, succinylcholine. That's when you see fasciculations. Those fasciculations that you see are of the skeletal muscle. You don't see their pupils go fasciculating, right? So we have written that, oh, the pupillary exam is not reliable because I gave the patient a paralytic. False.
Okay, so now we intubate the patient. Okay. What do you check first? Breath sounds. You check if the color change. Okay, gold is good when it changes from purple to gold. You have to have bilateral breath sounds, and then your end tidal.
Yeah.
This
So
is
what's
gold-
on a test question? What is the gold standard? You're going to check breath sounds. You're going to look for chest rise. You're going to get a chest X-ray.
end tidal?
End tidal CO2 waveform capnography. Whenever I intubate somebody or do a trach, that's all I'm looking for, is for that little yellow line to go up. The second that happens, I take a deep breath.
Yeah, we take a deep breath. Okay. So then now you just intubated the patient. So now the RT or the nurse they're gonna ask you what vent settings do you want. This is for you, Beatrice. Yes.
I don't know, because it depends on
Respiratory
So important
failure.
question is your initial ventilator settings for a patient who just got put on the ventilator.
you can do 100 FiO2.
Yeah, 100 is to start because they're usually hypoxic. Okay, so
You start with like physiology.
so let's do. There's 4 things, big numbers. This is very basic, but there's 4 This is the wrong one.
He's going to get in trouble.
So there's 2 things that we care about. We're in the bigger picture: oxygen and the CO2, right?
So oxygenation versus ventilation.
So then there's 4 numbers that you can play with at the beginning to adjust for them. There's 2 that are for oxygen, which are
FiO2 and PEEP.
FiO2 and PEEP.
All right, excellent. So oxygen's FiO2 and PEEP. PEEP stands for?
Positive and expiratory pressure.
Excellent. So it's going to stent the alveoli open.
And we established that atmospheric FiO2? 21. Okay. So then what are the other 2 things that we can adjust the vent for? The respiratory rate
All right, respiratory rate,
and
tidal volume.
so what's normal? 21 here, right? What's normal tidal volume?
6 to 8 cc per kg.
Kg of what? Ideal body weight.
Good. So
Right,
they
that's
just
a very
said
point.
6 to 8 cc's per kilo for ideal body weight. That's important because if somebody is super morbidly obese, the size of their lungs never changed, right? So you have to go off of their ideal body weight.
And how do you calculate ideal body weight?
Ooh, I don't even remember that.
Yes. Well, you need the height and the gender, okay? So let's say someone's ideal body weight is 70 kilos. You just tube somebody, what tidal volume are you going to give them? You said you're going to start them at 100, right? Which is fine. You just tube them, 100 is fine.
We put it at 7, and 7 times 7 is 49, so 490,
Oh, we're doing 7.
Yeah, 500, between 450 and 500. Okay? And then the respiratory rate, 18. It doesn't really matter, like between 10 and 20, but 18. You can start wherever. Not more than, don't go too crazy with 30 or 10. Just keep it in the teens, okay? And then PEEP,
What if though your gas before you intubated them, their PCO2 was like 70 and they were in a profound respiratory acidosis, right? Like they're a bad COPD. So one of our emergency medicine colleagues